Instead of chordomas or the SI joint fusion, there's going to be a straightforward thing. It's kind of a mundane thing. Multi-level cervical fusions, do you need a collar or not? But I think this is where there's a commonality in the room, because everybody does cervical fusions and we all do it slightly differently. Even among my partners, we have no data or no rhyme or reason why we brace people or how long we brace people for. So the case is straightforward. 62-year-old woman, gait difficulties over 9 months, poor fine motor movement in her hands, some pain in her bicep, so she has myeloradiculopathy, poor tandem gait, hyperreflexic Hoffman's. And here's her imaging. So she needs a 3-level ACDF. No movement on flexion extension. And what the question is, collar or no collar? What type of collar? How long are you going to wear the collar? And what makes you think that? And we have here the pro team on the left, Andrew Hecht and Ali Baaj with the happiest collar wearer ever. And then team headbanger, no collar. Beavis and Butt, no, Darrel, Brodke, and Khoi hand. So, gentlemen, take us away.
Thank you. Now we're getting to the real interesting subject matter. Forget the spondylectomies, forget the SI fusions, it's all about the collars. Here we go. So, in my disclosures, we talked about the patient. So remember, we are talking about 3 or more levels. We are not talking about 1 and 2 levels. We're talking about to use a hard collar or soft collar, what have you. Now, a belt and suspenders approach is often a very good approach when dealing with multi-level fusion. We don't want to be like this guy. We want to do things that are reasonable, effective, and can lead to success, like a belt and suspenders. Surgery, perfection is impossible. Things happen. We get pseudos. We get things like that. Are there things that we could do to minimize risk? And I think there are. Something that's very reasonable, simple, and costs nothing. When they surveyed surgeons around the United States, what do you do for 3 or more levels? Most of us use a collar. 1 and 2 levels, those numbers fall off exponentially. What about in Europe, or specifically the UK? Here we go, 3-level ACDF, who uses a collar? The overwhelming majority. The question is just for how long, and then that's where it varies from surgeon to surgeon seemingly. Why use a collar? Obviously, improve mechanical stabilization of long constructs. When you have less motion, you have a better chance of effusion, less complications, and then some psychological factors are almost a reminder. Stability will provide a more conducive environment to help increase the chances of effusion. Less motion is good. We know from when we see our own x-rays, when non-unions occur, it's at the ends, typically the bottom end. So why not do things that might reduce motion and promote effusion? What do collars do? They reduce motion. A hard collar, about 50%, a soft collar, maybe 25% or less, but often enough to achieve the desired effect. Why in 3-level ACDFs are much different than a 1 or 2 levels. These have much higher mechanical stresses. So even though they're pointless in 1 and 2 levels, they may be very valuable in 3 and 4 levels. So what do you want? Nothing? Or maybe one of these 2 options. You don't want to show up at Darrel Brodke's office hours with this x-ray, with a broken plate, hard rough pulling out, pseudoarthrosis. It's bad news all around. Not everyone here thinks they're Tom Cruise. We know there are risks to surgery, and we don't need this approach of no one needs a collar ever. So what does the literature say about collars? It goes both ways. In the JBJS, a big review, most of these respondents were talking about 2 levels or 1 levels, but in 3 levels, there's some benefit to collars. And the audience was mixed across the board. It often reduces pain, particularly in the short term, and may provide some stability in the short term when it matters most. There are very few randomized clinical trials of collars in 3 and 4 levels. We know that with the more levels that you do, the higher the non-union rate. And these numbers are being kind. 3 and 4 level non-union rates in the absence of autograft probably are in the 50 to 60% range. Every level increases the risk substantially. Now, not all of us can be like Darrel, who doesn't need anything. You just put a plate on and magically it's going to fuse. Is it enough for success? Fusion is a mechanical process. And the more stability that you have, It's better for osteoblasts. It's better for reducing fibrous ingrowth in your fusion. This is a biological process, and collars can help reduce cyclic loading early on. What about subsidence and other complications? Collars reduce early motion. And there are a lot of patient factors that often influence this. A lot of these folks are smokers, diabetics. You don't have the best fixation. That lady that we just saw here with her osteopenia may not have the best bone quality. You might want to have a collar. So what works? A collar can be a reminder to slow down a little bit. Soft collar, hard collar, it doesn't matter. It's enough to change what you're doing in your everyday life. You don't want the Utah Blue Plate Special. You don't want to start out with a 3-level ACDF, get hardware failure, non-union, and look what now you're doomed. So the support for collars is in 3 levels is unknown, but the biomechanics favor protecting this. And greater than a 3-level ACDF, collar remains a reasonable and good option. Yeah. Don't deflect down. Who likes risk?
Please. Baby done. But I still.
Admit it, it does ease my.
Who knew Darrel could climb so well?
He's done it.
Thank you very much.
Thank you for that entertaining video display. When I first heard what we were debating, I was so honored to be talking about maybe the most important thing we're talking about today, and that's to decide with zero data that I should or shouldn't do something based on essentially what I was taught or what the dogma is. And then I found out I was debating Andy, and I was nervous and uncomfortable knowing he would show videos of me that I had no ability to put equally good ones together of him, and it's all come to fruition. I'm going to be pretty brief. I'm just going to take the side of no collars, and I just have a picture of Andy here in a collar. It's a pretty good likeness of you. Maybe not quite as good as one you showed. And the point is, there is no evidence. And the downstream effects of a collar are not insignificant. And therefore, we should be thinking twice about whether we're using collars or not. Across randomized controlled trials, across symptomatic reviews, mostly at 1 and 2 levels, there is no difference between brace and no brace. We've seen it over and over again. Some of those studies also have 3-level cases, like the one we saw, and there is no difference in fusion. There is no difference in outcome scores. There is no difference in pain at follow-up, and there are no differences in complications. And in light of that, it is hard for a collar trying to hold a chin and essentially your shoulders in line to hold the individual levels more still than what you already have in this beautiful titanium plate that was put in to hold the level still. And that's why there's no difference noted in any of the studies in the literature now that we have internal fixation. Granted, when we didn't have internal fixation, we used collars, we used 2-poster braces, we used 4-poster braces. We tried to do everything we could to hold the neck still. A collar doesn't do that much, except cause problems. And these are just some of the problems. We see skin and pressure problems. We see dysphagia and dyspnea. We see reduced activities of daily living, sleep disturbance, can't drive, can't function in day-to-day life. Patients get deconditioned, and there is variable compliance. In fact, I might say every patient that comes back with a collar to Andy's office, that collar looks pristine because it was the first time it was put on. And the picture on the right is from Andy's office of his patients instructed on how to wear the collar. If benefit is unproven, even modest harms and hassles start to question. And this is the argument. We've heard the argument from Andy. It helps with pain. Maybe, but there's a lot of ways we can help with discomfort, not the least of which is education or a soft collar. It protects the fusion. There is zero data for that. Patients want it. Do they really? Have you ever had a patient want a cervical collar? Patients don't want it. They want reassurance. So the bottom line is we have no data to suggest that 3-level ACDFs need a collar. We have no high-quality trials. We have no clear signal. And we have a wide variety of practice. And the practice standards questionnaires that we get or give or have been shown by Andy are all we have what little evidence that is. The best available evidence out of UPenn showed no difference in readmission, no difference in direct cost, and no difference in qualities. Bottom line is no signal that shows a brace is valuable. Now, I might suggest that we reframe the debate a little bit, and that should a collar be routinely used postoperatively in multi-level ACDFs? Again, no evidence in 1 and 2-level fusions, surprisingly sparse evidence in 3-level fusions, and therefore a collar shouldn't be a knee-jerk reaction, shouldn't be a reflex. It should be a prescription when we need it. And so I might suggest that we actually consider times when we might need it. Patient is osteoporotic. Patient has poor bone quality for a large number of metabolic or medical reasons. Fixation is poor, as in the kind of plates that Andy puts on. Maybe you do need a collar. Good bone, good fixation, good carpentry, good management of bone biology, collar doesn't help. So, take-home message, a collar's not supported by any evidence in this kind of case. And therefore, trying to avoid harm, we should use it only selectively in high-risk cases. Thank you.
There's a clicker there. Okay, very good. I thought we had one clicker.
All right, good afternoon. Ali Baaj, I have no relevant disclosures, and I actually don't have slides either. I don't need slides for this debate, actually. And I'll share with you some information that you may not be privy to, but when we went through a lot of potential speakers and debaters because nobody wanted to be on the other side. Sorry for sharing that information, but I just want to let you know. I think nobody would agree to debate us on this because it's an easy topic. But in all seriousness, Drs. Brodke and Thanner have shown and will show probably, data and studies and outcomes, and Than probably will show some social media pictures and all of that to make fun of us. But the reality is they haven't talked about the most important person, which is the patient. They're not talking about the patient. They're not thinking about the patient. We use data and outcomes and studies to inform our decision-making, but we do not want our patients to be a victim of the mean or a victim of statistics. So when your patient, who has a 3 or 4 level fusion, asks you, Dr. Tan, you're saying I don't need a collar. Are you sure? Because I know other people who've had this surgery and they have collars. Are we taking any shortcuts here? Are you doing everything possible to actually make sure that I'm going to have a good outcome? What are you going to say to that? You're going to say, well, the study by Dr. So and that study, and we did a study on this. No, you've got to take the patient into consideration. Collars aren't just good for neck pain, and they do help fusion. They treat patients. They treat the psyche of patients. They remind patients that they had a serious surgery, and maybe they shouldn't twist and turn too much. They remind people who are with them or next to them that they had a serious surgery. We spend thousands of dollars on ACF surgery, so the cost is not an issue here. $200-300 for a collar after you put in thousands of dollars worth of hardware. Patients definitely benefit from collar. It's good for them. It's good for their fusion, and it's definitely good for their psyche as well. And you should definitely use it. Thank you.
All right, great. Well, thank you. That was very moving, Ali. I'm very grateful to be participating in this Cahill debate, and especially grateful to be assigned the winning side with Darrel here. These are my disclosures, and this is the case that Eric presented. So the question is, does this patient need a cervical collar after surgery? And like Darrel argued, the answer here is no. And the reason is because the abundance of the literature that exists comparing collar versus no collar suggests that there is no benefit to bracing after ACDF surgery. We'll quickly go over those. So this is a review of the literature from 2016. 7 articles specifically looking at fusion after ACDF surgery. Of those 7 articles, 1 demonstrated benefit to fusion. The other 6 did not. It resulted in the articles recommending against routine bracing after ACDF surgery. This was a study from 2018 out of Mount Sinai, a prospective randomized study funded by the CSRS, a great partner society to the section. 22 patients in each group, not demonstrating any difference in NDI, subsidence, or fusion rates at 1 year. And in fact, if you look closely at the data, at 6 months, the patients who underwent bracing actually had worse NDI at that time point compared to the patients who did not have a collar. You also notice that Andy was one of the co-authors here, so maybe he forgot to read this one before they submitted it. This is an Italian study, 36 patients in each group. Again, no difference in NDI at multiple time points or fusion rates at 1 year. This is another systematic review out of Michigan. Only 2 articles overlapped with the previous review of the literature I showed you. No difference in fusion rates, complications, pain, or quality of life. And I'm most fond of this one because the first author spent some time with us at Duke a few years ago, but in Korea they compared 45 patients without bracing, 38 patients with a collar, and again, no difference in MJOA, VAS, neck or arm, fusion rates, subsidence, or complications. When you look at all the studies, there's only one study that shows benefit to bracing after ACDF surgery. Written in 2013 by physical therapists in Sweden, comparing 16 patients without bracing, 17 patients with. They found improved NDI and neck pain with bracing at the 6-week time point. So this is the oldest study, the smallest study, the shortest study, and not written by surgeons. So every other available piece of evidence suggests that bracing offers no benefit after surgery. We've talked a little bit about cost. You know, my MEJ collar at Duke cost the patient $300. It's clear it doesn't do anything. And if I can quote one of my mentors and friends, Zia Koslin, I always remember what he says: if I need to brace my patient after surgery, I haven't done a good enough surgery. I think the only people who actually need cervical collars are our opponents, because they just got their asses beat. Thank you.
All right, well, thanks to all our debaters. We have team Beavis and Butthead, the headbangers, and then team Happy Cervical Collar Wearers. Oh, yeah. Headbangers, let's go. Great job, guys.